Hello and welcome to Yashoda Hospitals online segment Know Your Doctor session. Diabetic foot has become one of the most common and serious complication of diabetes and is one of the frequent cause of hospitalization and disability. So let's discuss about diabetic foot and foot care in our today's episode. I'm Dr. Lakshmi and today we have with us Dr. Devender Singh, consultant vascular surgeon from Yashoda Hospitals, Somajiguda. Welcome, doctor. So, doctor, can you brief us about yourself and your journey in this medical field?
Well, it's a very interesting story. Actually, I'm the first person in my family and to be honest, first person to be a doctor in my village. I never wanted to become a doctor because my background is from defense services. All my father, my relatives, they are from the defense services, and so as I was not very brilliant student in the school, early schooling, so I think I should go to the defense services. But then I think things changed. My mother, she was diagnosed to have a hole in the heart, a defect in the heart, and then that was the time when she was advised to undergo an open heart surgery. And those days I think the open heart surgery was very scary and full of risk. I still remember that I wrote a very emotional letter to the cardiothoracic surgeon, Dr. S.K. Kaul, that my mother, you are going to operate and please save her. And I also promised that I try to become a doctor, and that is how subconscious level I started preparing for that, and that's how the operation was successful. And then I met the doctor, and the doctor, Professor S.K. Kaul, he recalled my letter and he said, you have written me a letter and you promised that you will become a doctor. So what next? And then I said I will become a doctor. And since he was a cardiothoracic surgeon and my mother underwent a bypass surgery, so that is how my interest started in cardiothoracic vascular surgery. And then so from there, my journey started. I started inclined towards medical specialities, and I did my MBBS. I did my masters in general surgery from Delhi University. And I was the first student probably who requested for first posting to be there in cardiothoracic surgery. Nobody wants to go to cardiothoracic surgery department. So I was the first resident who requested the professor that I want to go to the cardiothoracic surgery. And then once I was there for a couple of months there. And then my boss, he only said, why do cardiothoracic and vascular surgery? You should do vascular surgery, because this is how the things are now changing. There is always a scope for subspecialization, and that is how I started falling towards the vascular surgery. I did my vascular surgery from Nizam Institute of Medical Sciences. I was the first DNB candidate, and then after finishing there, I went to St. Mary's London, which was sponsored by Vascular Society of India. I did my fellowship from St. Mary's London, and then I came back and of course, then I joined the Yashoda Hospital. It's been close to 2 decades now. I'm in Yashoda Hospital. Initially, I used to cover all 3 hospitals. Now I'm basically at Somajiguda Hospital.
I think that's a very heart-touching journey. So, doctor, you're coming from a defense background. If not a doctor by chance, what you would have been?
Well, as I mentioned that my father, my relatives, all in defense services. So my father wanted me to become an army officer, and I also, till my 10th, I was sure that I am going to go for NDA and to become an army officer, and then things changed a little turn, and then I entered into the medical profession.
So we are here today to discuss about diabetic foot. So to begin with, what is diabetic foot and how common is it in our clinical practice?
Well, diabetes is a chronic illness. Diabetic foot is definitely high on the rise, and we know that India is the capital of diabetes, and unfortunately Telangana and Andhra Pradesh seems to have maximum number of diabetes. When we have so much of diabetic load, definitely we are going to have a lot of diabetic foot. Approximately 15 to 20% of all diabetic patients will have diabetic ulceration in their lifetime. So the incidence is definitely, it's phenomenally very, very high.
So doctor, you've just mentioned that about 15 to 20% of all diabetic patients develop this diabetic foot. So why should we worry about this particular disorder more?
Every 20 seconds, one leg is lost. One leg is amputated in every 20 seconds because of diabetes. By the end of this discussion, we will be losing 60 legs. 60 legs will be cut by the end of our discussion. So it is definitely a very, very scary picture. What is more scary is that once a patient undergoes an amputation, that is the cutting of the leg, there is always a significant risk to the other leg, which is to the tune of 30 to 50% in the next 3 years. What is more scary is that these patients who undergo amputations, the risk of coronary events in the form of myocardial infarction or maybe a stroke is too high, and 2/3 of these patients, they die by the end of 5 years.
So doctor, apart from diabetes, what are the other risk factors that puts a patient at high risk for developing this diabetic foot?
It comes under the group of peripheral vascular diseases. There are many other risk factors like patient who smokes, patient who take alcohol, patient who has comorbidities in the form of underlying heart disease, underlying cerebrovascular accidents. So these are the patients who definitely are at risk of having a diabetic foot, and the risk seems to be very, very high. If the patient has got a history, hereditary history, also family history of diabetes, definitely these patients will have more risk to developing diabetic foot ulcers.
So doctor, what are the general symptoms of diabetic foot, or when should one suspect of having this, and when should they consult a doctor for this?
Diabetic foot is not an actually simple ulcer. It's basically a syndrome. We can call it a diabetic foot as a syndrome, which has 3 main components. Patient with an diabetic foot or an ulcer will have 3 components in the form of a neuropathy, in the form of vasculopathy, and an infection. It's basically interrelation of all 3 components. Now, patient with a neuropathic component will have both sensory and motor neuropathy. Sensory and motor neuropathy develops if the patient's sugars are not under well control and the patient has a long history of diabetes. What exactly happens in a neuropathy is that patients start losing their sensation, they are prone for trauma, they will not be knowing that they are hitting some sharp objects. And motor neuropathy, in terms of change in the biomechanics of the foot, the mechanics of the foot will change. Patients will develop a pressure sites, and more the pressure areas, more the pressure sites, patient likely to have these kind of insult, and then patient can develop ulcerations. Second most important component is a vasculopathy, which may be either a macrovasculopathy or a microvasculopathy. Macrovasculopathy in terms of maybe some kind of a blockage in the blood vessels, insufficient amount of blood flowing to the foot and the leg. That is a macrovasculopathy where something has to be done for the patient. Invariably, these patients will also have microvasculopathy. Patients' pulses will be palpable, but we see a common scenario in day-to-day OPDs that patient got a small ulcer, got treated somewhere, they did some kind of a sharp debridement, patient again came back with some kind of a involvement of the second toe, third toe, like that. So the reason of having a palpable pulse in spite of debridement, it is not healing, then the concept of microangiopathy or microvasculopathy. And third, the most important is the infection. Usually the diabetic foot people will have polymicrobial infection. It is not a single infection. Invariably these patients will have polymicrobial infection. So the only way out is that we have to have confirmed these things, neuropathy, vasculopathy, as well as infection. And once we confirm these, we have to treat all 3 components to give a better result to the patient. Otherwise, these patients bound to come back and they may land up in some kind of a serious illnesses and serious manifestations.
So you've just mentioned the diabetic foot falls under the category of peripheral vascular disease. So when is one diagnosed with this disorder, how do we go about?
Peripheral vascular disease, see, the thing is, it's very easy to diagnose the patient. Number one, if the patient has got some amount of comorbidities in terms of if the patient has got diabetes, if it is hypertension, cardiac problems, neuro problems, or kidney issues, we should suspect that these patients bound to have some kind of a peripheral vascular disease, because they are all interrelated. Patient with peripheral vascular disease will have a cardiac illness, patient with cerebrovascular patients will have a PVD. So they are all interrelated. Now, second thing is patient, most of the time we can diagnose these patients by clinical examination. If the pulse is there, that means invariably the patient will not have underlying peripheral vascular disease. If the pulse is not there, then that suggests that there is some kind of obstruction in the vascular tree, and then for that we need to confirm. We can confirm these things by doing a simple Doppler scan, and to further confirm we can have a CT angiography that will give us a correct and clear picture where exactly is the block, how much is the block, and what to be done for these patients. So the diagnosis wise, we should suspect patient who has got a comorbidities, patient who has a family history of peripheral vascular disease, and patient who presents with these kind of manifestations like pain which is not relieving, pain which is troubling them in the night, also what we call is rest pain. So these are the patients where we should probably suspect to have a peripheral vascular disease.
So doctor, how is a patient treated with diabetic foot if presented at the initial stages of the disease?
That's a very good question, because as we mentioned, that diabetic foot is absolutely a very common problem, and I'm sure all the specialists in their day-to-day practice probably will have these kind of a patient, as the diabetes is so much high in the population. Well, so far the treatment is concerned, basically we should always consider this as a syndrome, and we should know that the causes behind these things, the neuropathy, vasculopathy, and infection. We have to treat all these three components of the diabetic foot. Unless until we treat these component, then it is going to be very difficult. So far as the neuropathy is concerned, we should always try to press on the patient that they should be having a proper size footwear, which is very, very important. What is happening these days is that patient, sometimes they come to the OPD, they don't wear footwears, they leave their footwears outside, and I have seen a couple of the hospital and nursing home where probably they don't allow the footwear. For the diabetic patient, we must examine their footwear, and if the footwear are ill-fitted, these are the patients who bound to have repeated trauma, and they are going to come back with the kind of a diabetic foot ulceration. So first and foremost is that we have to have a good footwear. Second, most important is that if we have to map the foot and to see where exactly is the pressure, and we have to offload it completely. Offloading is a very, very important component in the treatment. We should offload, and so that we can take care of the neuropathic component. So far as vasculopathy is concerned, if it is a macrovasculopathy, like in terms of having a big lesion somewhere, we can either go for a bypass surgery, or if the patient is not very fit, we can as well go for endovascular treatment in the form of angioplasty or stenting. Third, the infection part, we have to first establish the diagnosis, confirm the type of infection. We just can't give patient a blind treatment. We have to have a swab test for the patient, we have to confirm the organism and see the sensitivity. As per the sensitivity, we have to plan for antibiotic regimen. So if we combine all three, the neuropathic treatment, vasculopathic treatment, and infective treatment, probably that is the way to treat the patient. Otherwise the patient are going to come back again with recurrence.
I think that's a very important point that you've just stressed upon, that wearing the right footwear prevents this complication. So apart from this, what are the other preventive measures that all diabetic patients can take to prevent this complication?
Well, diabetic foot management, when it comes to management, I think prevention is better than cure, and I'm sure that this is the best line for the diabetic patients. And we should always make a patient as a party to the treatment. It's not the responsibility of the physicians or the hospital. I think patients and their relatives are equally responsible for this, because this is a chronic illness. It is not that once I treat a diabetic foot, it's going to go away for the lifetime. No. Patients are bound to happen these kind of insult, these type of trauma. So I think we have to make a patient and the relative as a party for the treatment. We have to make them understand what exactly is the required, how to take good foot care. Foot care is very, very important. It is, for example, cutting a nail. It's so simple, it looks so simple, but in diabetic foot, it can become a serious issue also. If it is not properly cut, I think that can lead to a septic foci, and that can infect leads to patient into septicemia also. So foot care is very, very important. We have to compulsory stress upon the footwear. Footwear, we have already discussed about the footwear, and we should keep in touch with the patient. We should keep control the blood sugar levels. We should keep checking their glycosylated hemoglobin, because that remains an independent risk factor for the healing of the diabetic foot ulcers also. So basically it's a mutual kind of a treatment policy, where not only the healthcare worker but as well as the patient, the relatives, equally responsible for this.
So doctor, before ending this episode, what are your final thoughts and what message you would like to give to all the patients and general public out there?
Please treat your feet like your face. You will win the race. Don't neglect your feet. Take a proper foot care. Please wear a proper footwear. Ill-fitted footwear is going to harm you. Most important is lifestyle modification. That includes, please control your diabetic status. If you have any other illness in terms of cardiac illness, any neuro illness, any kidneys issues, please be in touch with your consultant, be in touch with the doctors, follow your medications, do not smoke, exercise. Exercise is the best medication for blood vessels, and diabetic foot is one where the blood vessels get severely damaged. So if we have to avoid this, I think the best would be to go for an exercise. Please make it a habit to have exercise at least 20 minutes in the morning, 20 minutes in the evening. Please do take good care of your feet like face, as I already mentioned. Thank you.
So thank you, doctor. It was a very nice and informative session with you today.
Thank you.
So this brings us to the end of this episode. We've been discussing about diabetic foot and its preventive measures. And do join us for the next week as well. Thank you and take care.